So what are we doing with the survey?
Okay, good. Okay, so that's a great thing. Okay. I feel like the quarter goes on, people kind of come later.
Welcome, everyone. Ooh, that's really loud. Sorry. As people are settling in, we'll start with a couple of class announcements. So we're going to hear about a couple new courses that are going to be offered, I think, next quarter. Sure.
So hi, everyone. My name is Rachel Katzenellenbogen, and I'm a pediatrician in the Division of Adolescent Medicine. And I've developed a course in collaboration with Dr. Manish Batra, who is a neonatologist who does a lot of global health research and is in charge of the global health pathway in pediatrics, the course that you see right up there. So it's a new spring quarter course called Global Health 590, Adolescent Health in Low Resource Settings. And it's just a one credit, no credit course on Tuesday evenings where we're really focusing on highlighting topics in adolescent medicine, understanding the context in which an adolescent is different from being a large kid and is different from being a small adult, and also understanding some of the specifics for healthcare needs, occupational health needs, law and ethics, and taking care of patients and working with adolescents to try to improve their health in settings where there are fewer resources, both internationally and, to be perfectly honest, in the United States as well. So just a short description, it's really a topic-based seminar course with a sort of introductory lecture and then topics that go throughout that include focus on reproductive health, STD and HIV in adolescents, ethics in the law and adolescents-focused research and clinical care, and programming around health in adolescents, environmental and occupational health and mental health and illicit activities. So it's going to be held on Tuesday evenings. I'll be there. Manish will be there. Dr. Walker will be there for one of the talks as well. It should really be a dynamic and hopefully a very engaging course, and I would invite all of you to sign up for it. So if you have any questions, my contact information is on these slides. We also have some handouts here that you can pick up and look up information as well. So thank you.
Hi, I'm Allison Drake. I'm a postdoctoral fellow in the Department of Global Health, and I just wanted to give you a brief introduction to a new graduate certificate that is just about a year old. It's the WACh Graduate Certificate. And this certificate will provide a comprehensive overview of global health of women, adolescents, and children, as well as address current issues in global health. And I'll let you read the learning objectives, but essentially there's a series of courses for the certificate, and then the final culmination of the coursework would be applied in a capstone project. So the course requires, or the certificate requires 18 credits. Only 2 of them are required courses. One of them is GH 544 that Donadetto teaches, who's here in the front row, and then you can take a Global Health 501 through 503 series or the Global Health 511 3-credit course. And then there are 9 electives that you can choose from that cross a wide variety of topics that sort of can be customized to meet your interests as well as your experience. So this is a certificate program that's offered and open to all matriculated graduate students across all schools and departments, and there are no prerequisites that would be barriers to enrolling in the certificate program. It's rolling admission. And then just a brief description of the capstone. This capstone project is a 3-credit capstone that incorporates the life cycle approach, which I'm sure you've learned about in this series, and will hopefully enhance the learning that you've experienced through your coursework through a hands-on experience that can be a wide variety of types of projects. There are lots of them that would be research-type projects, protocol development, data analysis, manuscript preparation, and then some of them are also non-research type projects, such as writing a clinical case scenario if you're a clinician, writing a policy memo or brief, conducting a needs assessment. There's really a wide variety of topics and projects that would be, I guess would suit the needs for the capstone. And then at the end of the certificate, you'd present your findings in a poster presentation. So I have packets of information about the certificate program. If anyone has any questions, you can contact me or the administrator for the program, Mike Ruffo. Thanks.
Okay, wonderful. So welcome, everybody, to our second to last session. I can't believe how quickly it's going. But we have a wonderful panel for you guys tonight, so I'm really excited to see so many faces. We'll launch right in. We'll get started with our learning objectives, and then I'll introduce our panelists. The first objective is to understand sexuality as a normal part of adolescence and the positive aspects of forming healthy sexual partnerships. Second, to describe reasons adolescent girls are at a uniquely high risk for unintended pregnancy and STDs, particularly in international settings. Third, to identify barriers to accessing adolescent reproductive health services, including social, economic, legal, and policy barriers. And finally, to identify policy and legal mechanisms to improve access to adolescent reproductive health services. So in order of presentation, let me introduce our wonderful panelists for tonight. First, you'll hear from Leslie WACh. Dr. WACh is the Division Chief of Adolescent Medicine and a Professor of Pediatrics at the University of Washington here and at Seattle Children's. She's the Director of the Leadership Education and Adolescent Health Maternal and Child Health Interdisciplinary Training Grant. That's a mouthful. Dr. WACh is the immediate past president of the Society for Adolescent Health and Medicine and has served on many other committees and boards. Dr. WACh has clinical experience in prevention and treatment of chemical dependencies, adolescent behavioral health, eating disorders, and gynecology. Her research interests include teenage pregnancy prevention. Next, we'll hear from Dr. Judy Wasserheit. She is currently the Vice Chair and a professor with the Department of Global Health here at UW, as well as Faculty of Medicine and Epidemiology, also at UW. She was the founding chief of the National Institute for Health's Sexually Transmitted Disease Research Branch, director of the CDC's STD Prevention Program, and director of the HIV Vaccine Trials Network. Pretty impressive background. Her research has included the first population-based study of the prevalence and etiology spectrum of STDs among rural women on the Indian subcontinent, and research on interrelationships between STDs and contraceptive practices in other parts of the developing world. Her work has had a major influence on HIV prevention policy and programs worldwide. Current research interests include developing and evaluating multi-component interventions to reduce STDs, HIV, and pregnancy among adolescents. Next, we'll hear from Sarah Ainsworth. She is counsel emerita at Legal Voice and a lecturer here at the law school. I'm a great admirer. Sarah has been was a staff attorney with Legal Voice for 10 years and currently teaches and writes about women's legal rights here at the law school. Her entire career has focused on social justice, from founding the Public Interest Law Association at UW Law School to practicing poverty law for Northwest Justice Project and Snohomish County Legal Services. At Legal Voice, Sarah worked to advance women's rights to be safe wherever they are, to have health care and reproductive freedom. Sarah continues her affiliation with Legal Voice as a cooperating attorney and a teacher and mentor to the next generation of women's rights lawyers. And then finally, we're going to hear from Shireen Noy. She is a peer educator and member of the National Advocacy Team for Planned Parenthood. She's first-generation South Asian American from Fremont, California. She was raised in Seattle and is currently a first year at Whitman College. Shireen has served as a peer educator for the Bellevue Planned Parenthood for 4 years, where she taught sexual health in elementary, middle, and high schools, as well as at several conferences. Last November, she joined the National Advocacy Team for Planned Parenthood Federation of America, where she'll work with college students to improve campus organizing in regard to sexual health. She's also active in several organizations on campus at Whitman. So with that, I'd like to welcome Dr. WACh, and thank you very much. All right, that's everybody's picture.
Yeah, I don't have any slides.
Oh, that's right. Even better. We'll bring Jen back up for that part.
Good afternoon, early evening, I guess. I'm really happy to be here because I think one of the reasons I really wanted to come is that I think sexual health is something that our country, globally, but also, more particularly, I'm going to speak to what's happening in the United States, is, we don't have a healthy relationship with our sexual health here in this country. And I really think that it's important that we begin to have a different understanding of what sexual health really means along the life course for not just adolescents, but from birth to old age. And I think we've had a hard time here. It's very torturous for women, and not necessarily just women, but a lot of people to try to understand what their healthy sexual life means and what it means as they're growing up, and they're understanding what their feelings are and how they want to express those feelings. So I hope, since you guys are in this class, that you'll be some of the people moving forward and helping to change that idea in our country and hopefully globally. Now, I looked around to try to find a good explanation or definition of what sexual health is. And the one I like the best is a little bit long, but it probably shouldn't be short. And it's from WHO Europe, the Europe side. And it says, sexual health is an integral part of overall health, well-being, and quality of life. It's a state of physical and emotional, mental, social well-being in relation to sexuality, and not merely the absence of disease, dysfunction, and infirmity. And that's usually, whenever I go even to my own conferences in adolescent medicine, when people say adolescent sexual health, the next slide is what's happening with STDs and pregnancy. We don't really talk about sexual health. We talk about the opposite of that, what happens when people express their sexual health and have bad outcomes, not what sexual health really is. And so it goes on and it says, sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all people must be respected, protected, and fulfilled. So I like that because it has the pleasure in there, the whole range of what sexual health really should be. And if you drill it down to adolescence, what I think that means is some of what David Satcher wrote in one of the links I gave you to his, I think it's probably one of the only national statements about sexuality and sexual health in our country, and trying to urge us to have a discourse. It was a few years ago, but one of the things he said about adolescence is, we need to discuss sexuality as being normal and a healthy part of adolescence. We need, it's not only physical, but mental, spiritual, It's a core component of who we are and how we live and who we hope to be. And without that, we really are missing the point on sexuality. I think when we don't do that, we see what's happening in our country compared to other countries. When we look at our country, it's not that people in the United States are having more sex than anyone else in the world, but we might want to think that with our media, but, when you look at it, people are having sex all over the world. But yet here, we seem to have a lot of problems with unintended pregnancy, sexually transmitted infections above and beyond what you would have expected compared to other countries we like to compare ourselves with. I was thinking when I was thinking about what to say, and my daughter's 20, so I've been around a lot of parents of kids who went through high school and middle school and their worries. And if I once heard, wow, look at my daughter, man, I'm so happy she's not sexually repressed. You never hear anybody, saying that. Nobody says that. What you hear is, oh, I hope she doesn't have sex in high school. Maybe we can even hold off till college. Maybe after college will be the first time. That's what you hear. Rather, you want to hear something like, wow, I hope the first time my daughter has her sexual experience with someone, it's really good, and she picks well so that, it's a good memory. You don't hear people saying that. And we probably should, because most kids are going to have sex absolutely before and if they get married. By, I guess, 20, most people have had sex. By end of high school, it's getting closer to 50%. It goes up and down depending on what's happening in our country, but most people will have a sexual experience, and you would hope that it would be safe, wonderful, fulfilling, and help them have a wonderful sex life for the rest of their lives. But that's not the way we talk about adolescent sexuality. And even if, we want to move to thinking about, being safe, it's really random whether or not a kid in this country learns anything about sexuality, even just their body, how it works with somebody else, and how to stay safe. You could have two kids in the same home, and they're going to different schools, and one might receive something and the other receives nothing. It just depends on where you're going. It doesn't matter by city. There's some schools in any city that might have sexual health education that would be appropriate to the age, and some that don't, even the most basic stuff. So we have a long way to go to just try to get, nice messages about what it means to be sexual and how to be healthy with it. When we did research, when I was in D.C., I worked at Georgetown for about 10 years before I came here. I was a part of a prevention of pregnancy program, and we wrote a curriculum for 5th and 6th graders. And the area that I talked about, and the area that I really focused on, was parents. And so we did a lot of work with parents, and what we found is that it was 99% African American and Latino parents. And what they said universally was, we wish the school would teach our kids something. One, because we don't know much, and so it's hard for us to teach some things that we just don't know. But two, because we trust the schools will be able to give them some of the information that might be hard for us to talk about in our homes. But yet that's not what happens. And research continues to bear that out, that most parents want good information, but most kids don't get that. So let's say we have the good information that, everybody is ready to express their sexuality in a safe, wonderful way. Then we have to talk about methods of pregnancy prevention. There are lots of different methods. They've been around since, I guess, men and women have been around to prevent pregnancy. But, and we keep working on different methods. And one of the things I think sometimes we do forget that I want people to think about is you can have all the methods in the best possible methods. If you don't think about the group and culture and people that you're bringing them to, they may be completely useless. You can have these methods, but we need to do a better job of looking at the people we want to use them and explaining to them. Within this country, there's still mistrust. Why is it that the government wants me to not have babies? What are you trying to say about me and my race or my group of people? There's still those feelings about birth control. So, sometimes pushing too hard begins to look like you're trying to change and stop me from producing more kids, in a way that's very negative for people. When we look at unplanned and young adult pregnancy, really young, right at the age most people are here, is the highest number of unplanned pregnancies. Adolescents have a high number, but it's that young adult, emerging adult age that it really just takes off. And one of the things that is really set to possibly change the whole landscape is LARCs, as we call them, long-acting contraceptives. And that is something that you might, Mirena, which you hear on the TV, the IUD, and Implanon. There'll be another implanted birth control method. Both of those, like the Mirena lasts 5 years once it's inserted, and the Implanon lasts 3. I think there's another one coming out that will last a couple of years soon. But those, anything else that's happened before, the longest an adolescent on average will use a birth control method is 3 months. And it's probably 3 months because Depo-Provera shot lasts 3 months and you can't do anything about it once it's in. But, the LARCs, if kids have good education and understand about it, if the doctors have good education and understand that it's the first-line choice for teens, it works really well. And we've already seen beginnings of decreasing pregnancy rates in places where there's more uptake of LARCs. So that's something to think about. That's why I also wanted you guys to just see the obstetric and gynecology recommendations that just came out a few months ago saying this should be the #1 first-line choice for adolescents when they're thinking about birth control. And, hopefully people will think that. One of the things that used to be a problem is it costs maybe $800, $1,000. So that completely stops most people, most adolescents, especially if they want confidential care, from getting it. But with Obama's Affordable Care Act and the particular last August, now if you have private insurance and your private insurance your new renewed private insurance as of August 2012, there are no more copays for birth control. And they also went back and made sure that in colleges there are no copays for birth control, and that women have the right to have these exams and have, pregnancy prevention planning and recommendations and treatment, like HPV vaccine, a lot of other things. So, there's still some problems because if you have Medicaid and you're in a state that doesn't want to give birth control, you might not, they have still the ability to not grant that. But for a lot of women now, they can go, and if you're in college, you can go and get some of the better methods without having to worry to pay $800 or $20 or $5. There's no copay. Hopefully that will expand to other people. Which is good. The area that is still of concern are people that aren't considered citizens. What happens with their birth control. There's still, you might say, well, now that everybody can get birth control, maybe we don't need the Office of Family Planning. But I would say, no, we actually really need the Office of Planning even more because there's a lot of gaps people have in where and how they can access birth control. We need places that are freestanding that people can feel safe and go to no matter what their status is to get care. And I did want to bring up one last thing, just with thinking about what is important, what's effective. One of the things Dr. Donna Deno, who's here in the Global Health Department, she did some work with WHO and put a paper together. One of the things I think is really important is the components to think about when we're talking is supervision of health workers after training, adolescent involvement in figuring out how to do some of this stuff and get the methods and the vehicles that they want to use. Activities generating demand among adolescents and support among parents and community members. But one of the main things I think it's important, especially when we're talking about medical home, is programs often need to work across sectors in order to be successful with adolescents. So saying you have a medical home for a teen doesn't necessarily mean they're going to get their sexual health needs met. They may need to go somewhere else for those needs and not go to their pediatrician or the family doctor that everybody goes to and sit in the waiting room with their parents. They may not want to do that. So it's important to remember that, as an adolescent medicine doctor, we sometimes are a little bit concerned with medical home and all the funding is going to go to one place to care for a kid, because for kids you need a number of places to care for one kid. So that's it.
Well, good evening. Dr. Walker just gave us a wonderful overview of several of the critical issues related to adolescent reproductive health. She focused primarily on healthy sexuality and pregnancy. She talked primarily at the individual level, bringing in some of the clinical issues, and then she talked primarily about the issues here in the United States domestically. So I'd like to build on that and talk about some of the other key components of the adolescent reproductive health equation. And specifically, I'm going to focus on prevention of sexually transmitted infections. That won't be a surprise, given what you heard about me, including HIV infection. And I'm going to talk about them because they are really important in terms of reproductive health. In fact, sexually transmitted infections, or STIs as we call them, are a leading cause of problems in reproductive health. Infertility, bad outcomes of pregnancy like low birth weight, prematurity, stillbirth, congenital infection, and they also increase risk of HIV itself. So we need to pay attention to them. I'm also going to talk primarily at the population level, although I'll say a little bit at the individual and clinical levels. And then I'm going to focus globally, particularly on what's going on in some of the low and middle income countries, although I will say a little bit about what's going on here in the United States. So as a springboard for our discussions tonight, I want to talk about highlight three key points. First one is that for adolescent girls, they really face a triple whammy with respect to sexually transmitted infections. So here in the United States, we estimate that about a half of all new sexually transmitted infections occur in 15 to 24-year-olds. And in fact, what we see is that the highest rates of STIs occur in adolescents, specifically teenage girls, and the youngest sexually active teenage girls. Okay, so if you adjust for sexual activity, that's where you see the highest rates. And the reason for that is this triple whammy. It's because biological factors, individual level behavioral factors, and sociocultural and legal factors really conspire against adolescent girls. The biological level, there are things like the fact that the concentration of the target cells for sexually transmitted infections, including HIV, are increased at the cervix if you're an adolescent. And systemically, there are factors that increase risk that float around. We call them pro-inflammatory cytokines because we always have to give a complicated name to these things. But these are also increased, and as a girl matures into adulthood, both those target cells and these systemic factors decrease. Adolescent girls are also at increased risk because frequently, if they're having sex with older men, because there may be increased trauma just because of a mismatch of anatomic size. You have a developing genital tract, vaginal canal in the girl, and you have an adult penis in the man. That's a formula for more trauma, and that increases risk of transmission. From a behavioral standpoint, what we tend to see in adolescent girls is a pattern that we call serial monogamy. Again, we have to give it this fancy name. But what that really means is that although most adolescent girls tend to have sex with just one partner, they cycle through partners more frequently, and the gap between partners tends to be shorter than in adult women. And if you are a sexually transmitted bug, you love that, because that is just exactly what you need to spread in a population. It's like, make my day, okay? So what we see in the United States, and Leslie referred to this, almost half of high school students have had sex. But by the time, and that can actually be okay if there is healthy sexuality preparation, the way Leslie talked about it. But what we also see is that by the time you hit 12th grade in the United States, almost a quarter of kids have had 4 or more sex partners, and that's a reflection of this pattern. The second behavioral issue is that we tend to see even poorer sexual risk perception and an increased difficulty in negotiating safe sex among adolescents. We as adults all have a fair bit of difficulty frequently accurately estimating risk and talking about condoms and other sexual partners with our partners. It's really hard if you're a 15-year-old girl, okay? The third thing is that the youngest, highest risk adolescents are more likely to have sex with higher risk infected partners. So, how many of you know a low-risk 35-year-old guy who's having sex with a 14-year-old? Doesn't tend to happen. They tend to be high-risk guys who are more likely to be infected, okay? And often in that setting, there's also an exchange of sex for gifts or money or drugs, which further increases risk. Then in terms of the sociocultural and legal risk factors, there are the issues of lack of access to adolescent-friendly preventive services. So the notion that it can be very hard to find an askable adult or a teacher to get accurate information, education, or skills training about risk factors for STIs or symptoms or negotiating safe sex. If you're a 15-year-old girl, it can be very hard to walk in and buy a condom. These are tough things. Then there's lack of access to adolescent-friendly curative services. It turns out that in all 50 states in the United States and in the District of Columbia, legally, minors are allowed to consent for STI testing and treatment. And in 31 states, HIV is explicitly specified. But 11 states require adolescents to be of a minimum age. It's usually 12 to 14. And in low and middle income countries, there's often no such law in place to protect adolescents and increase access. And even if all of that's in place, there may be confidentiality issues because most adolescents don't have independent insurance, health insurance, or resources to pay for services. So it can be, even if there is confidentiality and the provider, the doctor or the nurse doesn't inform parents, the insurance company may contact the parent to get payment. And I should have mentioned that actually in 18 states, physicians are specifically allowed to inform a minor's parent if they feel that that would help the girl, be beneficial to the girl or the boy. Many adolescents don't have transportation, so they have to rely on relatives or friends to get there, another problem for confidentiality. And the services themselves are often not developmentally appropriate or friendly for adolescents. It can be really hard. Then the second point that you really need to think about is that infection and pregnancy are totally different beasts if you're thinking about population-level factors and human behaviors. So your risk of pregnancy is really determined by the girl's individual behavior and her partner's individual behavior in terms of the human behaviors, right? But risk of infection depends both on those factors and on how common infection is in the population of partners with whom those people are having sex. So the population level factors mean that the social, cultural, and legal and policy responses are really quite important in this equation for infection. I should also note here that the contraceptive methods that are best to prevent pregnancy usually don't provide any protection against infection. And in fact, there are now data that suggest that some of the long-acting methods, specifically Depo-Provera, may be associated with a significantly increased risk of HIV infection and some other STIs. And there's a big debate globally about the significance of that, and we'll probably see some very important new research coming out of that. So that's a huge issue. The third and last issue I want to highlight is that there are special issues that drive the spread of STIs, to a lesser extent pregnancy, in marginalized populations, especially in low and middle income countries. We see them here as well, but it's particularly true in low and middle income countries. One of the major reasons is the low status of women, particularly young women and girls overall, and as is reflected in control of sexual decision making. This is because of limited educational and financial resources. It's because of limited social and legal capital for adolescent girls. It's because of early age of marriage. It's because of the double standard that often occurs with respect to sexual behavior. So the husband can have multiple partners, but the girl's not supposed to have any additional partners, so she doesn't perceive herself as being at risk. And if she has a symptom, she doesn't attribute it to an infection, so she doesn't seek care. You know, why should she? And it may also be influenced by higher rates of domestic or sexual violence. Another factor is, in many of these communities, is high levels of stigma, which precludes access to information or services even when girls do perceive risk. Another factor may be local traditions and beliefs. For example, in some parts of sub-Saharan Africa, there's a belief that if a man has sex with a virgin, he can cure AIDS or HIV. So then you want to have sex with a teenage girl. Another tradition in some places is the use of intravaginal agents to tighten the vagina to give the male partner extra pleasure. And this includes use of things like herbs or bleaches that are irritants, and they both directly increase risk by causing microabrasions, and indirectly by tightening the vagina, especially in an adolescent girl, they increase trauma just because of the size mismatch. And then, of course, very salient is the economic realities. Poverty is a great driver of sexually transmitted infections and HIV. So you know, in many of these settings, including here, you see exchange of sex for gifts, money, or drugs. In sub-Saharan Africa, you see what's been called the sugar daddy phenomenon, with adolescent girls, teenage girls, having sex with older adult males to get, you know, gifts or things they need just to survive. There are occupational arrangements that take large numbers of men away from families to work in male-dominated settings like mines, urban factories, or this happens with migrant farm workers, and then those males have sex with commercial sex workers and bring those infections back home. And then, of course, there's lack of access to quality STI or reproductive services. So, for example, by 2010, in Vulindela, South Africa, about 16% of 19 to 20-year-old schoolgirls, that's 1 in 6, was HIV infected. You know, unbelievable. So I'm going to close by leaving you with a couple of policy issues or questions that, of course, have legal implications that we might revisit in the discussion. First of those is, how do we frame adolescent reproductive health services? And Donna Deno, who's sitting over there and who's been alluded to several times here, was one of the people who really urged me to highlight this question. And Donna, you should jump in when we get back to the discussion, please, on this. But Just to give you a sense of this, in 1994, there was a conference, the International Conference on Population and Development, we call it the ICPD, in Cairo. And this was really a milestone because it shifted from framing reproductive health as a population control issue to framing it as a human rights and development issue. And it placed the equality and empowerment of women front and center in that equation. Called for universal access to family planning and sexual and reproductive health services, preventive and treatment services, and specifically highlighted that that should include adolescents. So now, as we come up on the 20th anniversary of that 1994 ICPD, and also in 2015, we moved from the Millennium Development Goals to the new phase, which may be Sustainable Development Goals. And at the same time, we have Melinda Gates down the street really pushing on family planning, which is wonderful. But, you know, this is all coming together at the same time. I think one of the questions is, do we maintain a human rights framework for thinking about sexual and reproductive health? Or do we frame it more in terms of population control and its benefits for health, climate change, and other outcomes? Or do we do both? And more importantly for this discussion, what are the policy and legal implications? Because the way we frame it changes what you do about that. And then second, what are the implications of the advent of new preventive technologies and approaches for policy development and supporting laws? So there are several real game changers with respect to STI prevention that have recently emerged or are just about to hit us. You know, things like HPV vaccine, which was mentioned, HIV pre-exposure prophylaxis, which was just approved by FDA, microbicides, and state laws often here distinguish between STI preventive services and diagnostic and treatment services for minors. So, for example, only 7 states actually allow minors to consent for STI preventive services as opposed to diagnosis and treatment. This is in the United States, and one of the articles that I asked Jen to put up talks about all of this. So, you know, pre-exposure prophylaxis, what we call PrEP, may actually hit some major roadblocks with respect to adolescents' access. And because it's seen as much more invasive and has more potential side effects than other preventive technologies like condoms. Okay? So the question, another question we might think about is how can legal or policy approaches be developed in concert with, in tandem with the development of these technologies so that, you know, the launch pad is prepared for marginalized populations or for adolescents. So let me stop there. I look forward to our discussions. Thank you.
Okay, I'm just going to pull up a slide. Presentation format on you. I really appreciate all that was said before me, especially the discussion about what kind of framework we use to formulate policies and laws that impact reproductive health and sexual health of adolescents and everyone. And in the United States, activists who were there in Cairo during the discussions that were going on about international population were the first to create the term reproductive justice to describe a movement in the United States to marry the ideas of reproductive rights with social justice and economic justice. And so my presentation also kind of comes from that framework, and I will try to touch on it at times when we go through it. So I have expertise really in policies in the United States, not global policy. I'll try to mention global policy where I do have some understanding of it, but my emphasis is going to be on policy here in the United States. And I also do not have very much expertise in the issues that Dr. Wasserheit just talked about around STI infection, but in some cases my expertise and experience overlaps with that, so I'll bring that up when it comes up as well. So the way I tried to frame our conversation today, oops, that's not the right way to do it, is that adolescents need access, and they need access in 3 key areas. They need access to information, they need access to health care services, so reproductive health services broadly, and they need access to social support to have full sexual and reproductive health. So let's talk first about information and U.S. policy in particular and how that impacts access to information. So we have, all of us get information from family, from friends, increasingly from the internet, and from some pretty impressive websites actually that provide information about sexual and reproductive health. We get information from healthcare providers when we have access to them, but official government policy also has this tug-of-war of ideologies that impacts where we get information and what kind of information we get. So we have had, since 1996 in the United States, federal money directed at abstinence-only until marriage education programs. And the focus of those programs is to discourage young people from having sex at all unless and until they get married. So, of course, this leaves out entirely lesbian and gay people whose sexuality is completely denied, whose existence is essentially denied and disparaged in these programs. And it also leaves out anybody who doesn't envision themselves as entering into a marriage or who just doesn't ever get to get married, and leaves them out entirely. These programs also must not teach about contraception, how you use it, where you get it, and certainly not about abortion. Okay. So that's government policy. Now, since the Obama administration has come into office, the amount of federal dollars that is directed at abstinence-only education has decreased dramatically. But there was hope among people who advocate in this area that it would be eliminated, and it has not been eliminated. There's still millions of dollars available for abstinence-only until marriage education programs. But at the same time, we also have federal money through the Affordable Care Act for programs that provide more comprehensive sexuality education. These programs do teach about how to prevent pregnancy through using contraception, how to prevent sexually transmitted infection through using other methods that are, and explains why some work to prevent contraception but don't prevent STIs, so somebody has the full range of knowledge. They include relationship, healthy sexuality education. They're inclusive. They're meant to be culturally appropriate. Now, we have a long way to go to make sure those programs are actively working and actually getting funded and present in schools, but we do have these completely competing ideologies. And so I wanted to show you a couple of pictures that I think help point that out a little bit. So here's the abstinence-only policy, kind of in its full. Not doing it until I get married. Fine, a fine choice, right? But the pressure that comes from these programs comes with this. And then you see, this is also government funded. This is directed at older adolescents, so college students. And what it says here is, you didn't give up on sex, so don't give up on birth control either. Click here and you can find ways to, get the birth control you need. So you see a much more sex-positive approach in one and a much less sex-positive approach in the other. Now, before I move on to this slide, I did want to mention really briefly that states also make policies around sex education. So in Washington State, for example, if a school teaches sex ed, it has to be comprehensive, but there's no mandate to teach sex ed. So as was expressed earlier, you can have a variety of experiences for students across a school district, even from year to year in a particular school, and there's not a lot of enforcement available in that law. So while we have a law, we still have a patchwork of information available. Now, the same thing is true a lot of times with access to healthcare services. And so since there's so much to say in this area, I've tried to just touch on a few things, and I'm going to go through them really quickly. Confidentiality for young people with their healthcare providers was really already touched on, so I don't want to get too much into detail around it. But I'll talk briefly about mandatory reporting, because that comes up in that context. So mandatory reporting laws are present in many states, and they're essentially directed at all kinds of professionals who are supposed to report to the police when they believe child abuse or neglect is going on. And many, many states have been urged, and some do, believe that anytime they see an adolescent having sex, that's evidence of child abuse or neglect because of age of consent laws. And so there's an effort to try to get providers like at Planned Parenthood and other organizations to report every time an adolescent comes to them seeking birth control. So you can imagine the conflict ethically that the provider faces, as well as the legal issues there. So there's a lot of, and my legal analysis is that you don't have to report unless you believe there's actually child abuse and neglect, and that sex alone is an evidence of that. But that's, not every lawyer would say the same thing. So. Minors' rights to consent to treatment, we touched on that briefly. In Washington State, minors have rights to consent on their own without parental involvement to sexually transmitted infection diagnosis and treatment. They have the right to consent to get contraception and to get abortion without involving their parents at all, but that's very unique. We're one of only a few states that don't have parental involvement in minors' abortions. So in the vast majority of states, a provider cannot provide an abortion to a minor until they give notice to a parent. In some states, consent of a parent is also required. As was mentioned earlier, insurance coverage, that's the way we provide care to people in the United States, and that differs in other countries. It's not how it is around the world. Some countries have universal health care where everyone has access to health care automatically, but we don't have that. We have this insurance scheme, and even though the Affordable Care Act may increase access for many people, it brought with it a lot of prohibitions on immigrants getting access to care. There's still a 5-year waiting period for immigrants who are here with certain status in the United States, and for immigrants who come here without documentation, they're just absolutely excluded from any kind of federal health insurance program. So unless a state makes up the difference and provides some kind of public funding, then the only way somebody can access services is to either get them at the emergency room or pay for them out of their own pocket, or try to get on an employer's insurance scheme. But many immigrants who come here without documentation are working in low-wage jobs where they don't have access to insurance. So, and this affects adolescents dramatically. Even adolescents who are born in the United States but have immigrant parents, so they have different statuses in the same family. And so adolescents who might put their parents at risk by trying to seek care are afraid to do it. So it's a very big issue. And of course means that there's a lot of young people who are particularly vulnerable but don't get the care that they need. Pharmacies I brought up because this is a bit of a case study that I want to just touch on really quickly, and this is the issue of access to emergency contraception. So this sort of shows registration status, meaning these countries some of these countries have a dedicated emergency contraceptive product. So the red countries have a product that's registered and is available to everybody over the counter without a prescription. The orange countries have a dedicated product that's available to most people over the counter without a prescription with some variety. The blue countries just have a product, and it's not entirely clear how it's provided to everybody, at least through this map. And then the the purple countries don't have any kind of dedicated product. It doesn't mean that doctors can't provide emergency contraception by giving people regular hormonal birth control pills, but there's no actual product there. So how people access these products is completely dependent on the legal structures of the various countries that they live in. And so in the United States, we approved this drug. Plan B is the primary drug that is emergency contraceptive product, and it's available over the counter for people 17 and older. But you have to go to the pharmacy and you have to show proof of age in order to buy the medication. Moreover, a recent study came out just last year of several urban areas scattered all around the country, and they called pharmacies and pretended to be teens and asking, how can I get the drug? And the vast majority of pharmacists gave teens the wrong information. They said, you can't get it at all till you're 18. Or you can't get it at all when you're 16, and even if you try to get a prescription, you can't get a prescription. Like, they just did not know that anyone can get it with prescription. 17 and older can buy it over the counter. That information was just not provided. So there's huge barriers to teens actually getting this medication, even though it's totally safe and available in many countries. It's available not just over the counter, but actually provided in schools. So in France, that's one example where it's provided by school nurses for free to people ranging in age from 12 to 17 with no adverse impact. Now, the last thing is social supports. And teens need social supports to get access to abortion. They need to not feel that there's shame, that they are going to be ostracized for getting that service. The same is true of contraception. But I picked this particular case study to point out that when young people do have children, we have had in the United States such a push, such an emphasis on prevention of teen pregnancy that there's it essentially demonizes teen pregnancy, and it results in some really serious problems. So here's a PSA that's going on in New York City right now. This is all over the internet if you want to take a look. This is one of 4 different ads that they're running in subways and at bus stations. Thinking about this, through a lens of reproductive justice, in almost every ad, the child is either, it looks like they're a child of mixed race or a child of color, so it's like directed at particular groups of people who are discouraged from being parents. And some of these statistics that they cite are not necessarily inaccurate, but they don't go back far enough to note that poverty actually increases the risk of becoming pregnant as a teen because of all the lack of access that we talked about earlier. It's not that teen pregnancy is the root cause of poverty in the United States. So this is quite controversial. Planned Parenthood in New York has come out saying stop shaming teen parents. There are a lot of efforts to try to support teen parents. One of the things that's going on in Washington State is that the ACLU of Washington is doing a study of teen parents who've been pushed out of their schools, which actually violates both federal law and state law. You see girls being told, you can't finish up here because you've made this bad choice, and obviously you're not really wanting to finish high school, or they get pushed to alternative schools, or truancy laws get used against them, saying, no, you can't miss another day for a baby's doctor's appointment, no, you can't miss another day for your own prenatal care appointment. All things that are not true and violate the teen's legal rights, and yet nonetheless push teen moms in particular out of school. So to support them, we can provide policies that do these kinds of things, help them stay in school and finish up school, help them get to college and stay in school, help them with child care resources and access to public benefits, and helping them breastfeed, helping ensure healthy children and healthy pregnancies. So all of these things together, if we had them, yay. So much more to say, I think, about this issue, but I'm going to stop now so we can talk more during the break and pass it off to the next panelist.
Good afternoon, everybody. I'm really happy to be here. I'm actually on spring break, so I'm really happy to be back home. And I'm really happy to go after all of these panelists. I think one word that came up a lot was support. And I guess ending the panel discussion, I'm going to talk about my own experience with working with Planned Parenthood as a peer educator, and also from the perspective of someone who is not quite a young adult, still kind of staggering in the adolescent range, and what my perspective and experience has been with that. So I'm going to start, I work with Planned Parenthood, and so the program that I was part of is called Teen Council. It was started about 20 years ago, so it is fairly recent, and it was a program that was started by adult educators in Planned Parenthood who wanted to educate students who were in high schools who weren't getting comprehensive sexual education. So even today, sexual education in schools is not that comprehensive. About a year ago, exactly a year ago, I was still in high school, and so I had the experience of being in a sex ed class from about 7th grade and not really learning anything. The topics that we covered in Teen Council were STI, STD, safe sex options, birth control options, abstinence, and so on. And recently we've also added gender and sexuality as well as race and ethnicity, which has been really awesome to have the intersection of all these issues that we can present to students. The teenagers who are trained to work in teen council, they range from about 14 to 18 or 19 years old. So the cool thing about it is that we're able to go back to our own schools or other schools in our community and teach the very issues that we either learned or didn't learn in our high schools. My experience is that I came from a household where we did not talk about sex. We didn't talk about anything related to sex. And my theory now, being in college and being away from home, was that A, either my mother didn't know about sexual health or reproductive health, or B, she assumed that I would learn from peers or my school or people around me, adults. So it was never really discussed. So I went into high school not knowing anything and learning from teachers who were in a program that was very much into like only the school that I came from. So I went to a Catholic school, a Catholic private school, and so things that we talked about there were not talked about in the public school system. My teacher left out important issues in relation to gender and sexuality. It didn't really highlight how one can protect themselves during sex, and also it was from a very heterosexual perspective, so it didn't assess the gender issues. And we never really touched on topic of consent and healthy relationships. So girls learned the very surface level or basic things of sex, but didn't really go into detail about it. So my freshman year of high school, my sister was volunteering with Planned Parenthood, and she worked as a phone banker. And she found out about the Teen Council program. I decided to apply to it. I went into it really not knowing anything. So the experience for me was that simultaneously, I got a holistic understanding of sexual health and reproductive health education while teaching what I was learning at the same time. So it was very much a balanced thing that I was experiencing. What I gained from that was confidence. I also became a peer resource, which was one of the most important things for me because I was able to be a resource directly for friends who weren't able to get the same resources I was getting from Planned Parenthood. I became more aware that these issues are not shameful or dirty, but are extremely important for young people to know. So why does sexual health education, why is it so important for peers to be a part of that, especially my peers? It allows young people to contribute towards their own personal development in regards to things that they're personally experiencing. One of the most unique things about Teen Council is that we have teenagers, 14 to 18 years old, going in and talking to their peers who are the same age as them, come from the same experiences. It's a very diverse background of students who are going in and teaching students. What I've seen personally as something that was beneficial from that is that we don't have a hierarchy. It's not adults talking about something that they either experience or not experience. It's teenagers talking to teenagers, which sometimes comes into play as something that's a little bit ridiculous. There's definitely been run-ins in classrooms where it's been, I was a sophomore in high school going in and teaching seniors in high school. It was a little weird. But in the end, it makes it more relatable. And the second thing is that it enables young people to make more informed choices about their sexual behavior and relationships through education. The main issue that I've seen in high schools and even in my own college is that people are not educated. And this is a problem that's directly coming from the system. This is not the teenagers' problems. People come from all different backgrounds and all different households, and I have been told my entire life that I'm supposed to figure out what it means to be a woman, what it means to get my period, what it means to be sexually active through the media and through a very surface level education, which is not holistic at all, and it doesn't really make sense. Third, it enables young people to be an effective resource for their peers and people that they can relate to. I talked about the idea of being able to relate to someone in a classroom, but it really is a big deal. I wish that when I was in high school, I would have had the opportunity to sit in a classroom setting when a teen council member could come and talk to me, where a young woman would stand up here and tell me how to put on a condom. That would have been awesome. It would have been better than having something that was someone who was telling me not to have sex, because teenagers, whether we like it or not, are going to have sex, and it's better to give them the tools to protect themselves than to tell them not to do it. There's a lot of shame and guilt associated with sexual and reproductive health care, and one of the things that peer education eliminates is that shame and guilt. It enables young people to understand that standing up in a classroom and talking to teens like themselves is okay. It's not a big deal. It should be something that's talked about. Going to Whitman I'm a first-year student there right now. I assumed that people would know about sexual and reproductive health care, and I was really wrong. It was shocking to go into a college environment where I thought that everyone was going to be educated, everyone was going to have the same background that I had, and it wasn't like that at all. On our college campuses, thankfully, we have counselors, we have health centers, we have people that they can talk to, but it's still not something that is publicly discussed. I've never had a discussion with someone in my section, in classes, about sexual or reproductive health care. And a lot of the times, the way that I've been able to advertise myself as, come talk to me if you want to know something about birth control options or STDs and STIs, is I have a note on my door that says, come and talk to me. I'm a peer educator, I'm a peer listener, and I got trained as that, and so that's the only way that I've been able to have girls come in and talk to me about things, because there's so much shame associated with it. So I think the solution, and I guess this is a very idealistic solution, because there are going to be run-ins. Definitely we've had run-ins in schools. Not every school or public school system likes what Planned Parenthood is doing or likes what the peer education program is doing, specifically private schools. As a society, we need to keep talking. We need to encourage our children to keep talking, our peers. We need to encourage young people to keep talking to adults, as well as young people to keep talking to young people. And I think that's the only way that we'll be able to encourage a more holistic sexual education program. Thank you.
Great, thanks to all of you. And I think now we'll open it up to questions from the audience, just so that our panel knows our class officially ends at 6:30, so we have some people who do have to leave, but we've sort of established this procedure where we ask questions for the last half hour instead of our reception, since our food has sort of declined in quality. So anyway, so I hope you all are willing to entertain some questions, and does anybody have any? Go ahead. And just to repeat the question for the recording, if I hopefully can summarize it okay. The question is, we've talked a little bit about the resources or lack thereof for homosexual sexual education in schools. What about in the healthcare setting?
Probably answer that. I think that it's variable. You know, I think that there are many people, I mean, in adolescent health, yes, of course, people that are trained as adolescent medicine doctors routinely ask that. There are about 600 of us in the country, so that doesn't make much of a dent. But, you know, it's mentioned that you should talk about it, but people individually have their own comfort levels, and I think there's a lot of variation in, you know, people I know that are adults as well as kids try to look for a network where they know that, you know, these are the doctors that they can speak to about it. You know, it's harder for a kid to do that and to be able to move around. So I think it's pretty, I would bet it's pretty poor on a general.
You know, I think that from the perspective of providers of care, preventive or curative services for STIs, there's, including HIV, there's not surprisingly a lot of sensitivity to the issues related to gay and lesbian communities. Interact a lot. Some of us do it better than others, but I think there's certainly an awareness that this is a very important population and we need to work hard to provide appropriate care.
Jen?
The question is whether social media is being used for the good to, with respect to reproductive health, education, and et cetera. Go ahead.
Planned Parenthood does have some stuff. I know personally I'm from the Bellevue Teen Council. We came out with a video last year, which was about, it was a fun little video to promote sexual health and healthy relationships. I don't think that I personally have seen anything else that was specifically targeted to promote safe sex and healthy relationships and I guess reproductive health care anywhere else in the media besides organizations that are specifically helping with reproductive and sexual health, which is really cool, but it would be also better to have other organizations or the companies who are promoting that as well. Because I think the stigma specifically related to sexuality is that we're supposed to be sexy without being sexual, and there's a double standard with that, especially among young women who are in high school and college. So it would be great to have those resources available.
There's the campaign to prevent teen pregnancy, or to prevent unplanned pregnancy, has something that's actually very elegant and very exciting. The bedsider, which you had one slide from, that's been developed and they did the kind of marketing that a company would do to look at teens and young adults to see what would be appropriate. We had somebody come and present it at our adolescent health meeting, and it was kind of edgy even for the teen docs. And so one of them got up and said, well, I don't really think this is appropriate. And so she said, yes, that's the way it's supposed to be. It's not for you. And so, I mean, they have some really great things about birth control methods and sexual health that I think it's geared right toward most of the people in this room's age group. And I think that's great. But I don't know how many people know about it. They've been putting a national campaign out.
I'm glad you mentioned that. Yeah, so the slide I showed with the pants, that's Bedsider. The two skinny jeans, that's bedsider.org. So you can check it out. And I was just going to say, though, competing with the cool thing at Bedsider and some of these other messages are crisis pregnancy centers, these organizations that oppose access to contraception and abortion, and they're very, very well funded, and they have some very slick PSAs and social media. They're on Facebook, they're on Twitter, they're on everything, and they have literally millions of dollars in funding from organizations like Focus on the Family to try to discourage young people from having sex and also getting abortion and contraception. So competing with these other messages, we have the anti-messages as well.
Lots of hands. Okay, right here. So the question is a hypothetical. A teenage girl, 15 years old, goes into one of our local hospitals in Seattle and says that she may or may not be pregnant, may or may not have an STD. What happens?
I think if she actually said that, she would get the same care. You know, I mean, the hospitals that you mentioned, of course, you know, they actually see that a lot. I think the issue comes in when a girl will come in and say, my head hurts. But really, she's coming in because she's had sex and she's wondering what to do. And so, you know, the savvy, the ability of an ER, you know, individual ER doc to realize that it's not the headache, it's the fact she just had sex and they need to talk to her alone might vary a bit. But I think most people know that the standard should be to speak to a teen alone for a certain bit of time, and that's the goal. Yeah. Oh, no, but again, no. If they, everybody knows the law, but most of the time kids don't say that right off in the front in the open with everybody else sitting there waiting to be checked in. So it's you have to be a little more savvy in figuring out what they want.
And, you know, I'm not answering to what the medical providers would do in this context, but the one caveat I know about is this issue around emergency contraception, and that has to be provided to rape survivors in the ER, but some providers really object to emergency contraception. They see it as tantamount to an abortion. So at my office, we were involved in helping a teenager who was in an Eastern Washington hospital, went with her mom after a rape, and was refused the care by the doctor on duty. The male nurse who was on duty actually, in the middle of the night, got this drug for her and then called us the next day to file a complaint to see if we could do anything about it. So there is that risk when it comes to seeking emergency contraceptive care in emergency rooms around Washington. The law requires every single hospital to provide it regardless in Washington State. She should be able to get it at every hospital. We don't see total compliance with that law.
Next question. So just to quickly paraphrase, the question is, with the merger of secular and Catholic hospitals that's more and more prevalent, and apparently about 12 are going to be happening here in the Seattle area, what are the implications for reproductive rights and health?
It's a huge issue. It's an issue around the country. And I mean, I think you've actually went ahead and explained what will happen. I mean, that's the risk that what will happen. Now, there are legal ways that communities can push back, but there's not a lot that people can do in the law to stop the mergers from happening. So communities around the country basically band together and mobilize to argue that reproductive health services that were provided prior to the merger must continue to be provided. And so you see that effort in Washington State. There's a lot of people working on the issue. Here locally, my understanding is that there's been a lot of talk on the part of Swedish that it intends to continue to provide those services and it's going to find a way to do it. But there's also been a lot of reports that that's not accurate and that may work in some capacity. They are apparently going to fund a Planned Parenthood clinic and refer people there, but that's not going to work for the woman who, you know, wants just a tubal ligation right after she's had a C-section. Like, Planned Parenthood can't handle that kind of service. It's not going to necessarily direct what the doctors in their practices do. So it's a really big problem around the country, and I would encourage people to look at the website of the WACh project, which is based in New York. They have a lot of details about how communities have dealt with that. And there's been some discussion of trying to deal with it through legislation, but at this point, there is no legislation in Washington State that addresses the issue. So thanks for bringing it up.
Question in the back? A question about whether there's been any consideration given to how teens can access or figure out a way to still have insurance or their parents' insurance without necessarily having the parent, I guess, find out everything that they want to. Mm-hmm.
I'm not too familiar about all the insurance stuff, but I know that there's a program that kind of models the issue of confidentiality, and it's called Take Charge. It's a program through Planned Parenthood where anyone, I guess, can apply to get birth. One example is get birth control. When you go into the clinic, you have to just fill out a couple forms. You need your social security number, which is the only thing. So if I'm going to use the example of a young woman can't get her social security number from her parents, and that's the only thing that would be an issue. But if you have your social security number, you know your address, you can get birth control from Planned Parenthood, and I think it's covered. They also do something where it doesn't necessarily have to be mailed to your house. You can go and pick it up, or it can come in a confidential kind of box. We haven't really discussed, in the teen program, I don't think there has been anything about insurance. Our main thing is going into schools and talking about sexual and reproductive health, but I think Take Charge is the closest program in terms of what people can access. There may be other programs that I'm not entirely familiar. I don't know.
I think it's very difficult. I know when I came here, we were thinking about having Take Charge, and we actually cannot. I don't know. I guess it's still in effect for those that have it, but you cannot apply to get it anymore. The funding is down, so that you can't really, if you don't know the few places that still have it, or some of the school-based health clinics, you might not be able to access that. I think that the insurance is very difficult. I think adults have a hard time navigating insurance, and it's going to be interesting to see as the Affordable Care Act rolls out what that means. Typically, adolescents are left out of how do you sign it. You can't really sign up if you're a teen. To most, except for something like Take Charge, or California has sensitive services, which is much better saturated in the state. But how do you sign up when you don't have the information? Your mom's not signing the form. When you're 18, I guess you have the option to sign up. And when some of the things change, where at 18 more people can come onto the rolls and sign up if they don't have a job. I don't think it's right now, though. It's coming up.
That's right. Under the Affordable Care Act, there's meant to be an increase in access to insurance as well as in access to contraception within insurance. But the one thing that is in effect right now is that teens can stay on their parents' insurance till they're 26. And that's actually a question I don't know the answer to, and I wondered if medical providers do. If you report a particular service provided to an insurance company, how does the insurance company report that? And of course, that does come back to the parents, right? And they see what kind of service was provided. So I don't know how cryptic they can be about what service, and I don't think they are, right? So that's an issue.
Yeah, I think this is exactly the issue. It's not that they don't have coverage, it's how that coverage then could violate confidentiality for the parent, and I don't think that's been well worked out for teens. I don't. Well, yeah. But in this particular case, I do, the one other option for infection prevention and treatment of infection is to go to health department clinics where, you don't necessarily need to, if you don't have resources, the minor would just, insurance wouldn't be a question. But many adolescents wouldn't either know about or feel comfortable going to the health department STD or STI clinic, even though it just so happens here in Seattle-King County, it's probably one of the best clinics in the world. But
just to add to that, I know that on my college campus, there's a program that you can be covered under the student health insurance, and so there's a package that Whitman College is doing right now, which is like a comprehensive sexual health preventative package where you can get an STI testing, HIV, and then also get something for birth control. But it's like $150, and it comes up on the report. So it's kind of like, okay, well, this goes back to your family, and your parents are like, $150 for what? So I'm not entirely sure what it comes up as, which is another loophole in that. Okay.
Who is very, very defensive and mad at my turn. He says it's bad behavior and we should. Shame is a good way to stop it.
Let's go to the back.
There's been a ton of studies actually that measure change in behavior because they're directed at behavioral change, right, in reducing the incidence of sexual activity. So there's been government-funded as well as private studies. And the abstinence-only education has been found unequivocally to be ineffective. There's only one study, and it was about a small cohort of middle schoolers that indicated who had an abstinence-only message, which seems age-appropriate to me when you're 11, you know. But they got that message and they delayed sex. They didn't have sex when they were 12. So there was that one study, and that came out about a year ago. But otherwise, no, it's not been effective. Politics, right?
Yeah. The other thing is there are a lot of studies out there. There's a special journal that has research that most people that do research wouldn't consider real evidence-based and high-level research. So there are some, if you look, you might find studies, but if you actually critically look at the article, they're not the kind of studies that most researchers and scientists would say proved anything. But there are a lot of them out there, so you'll see them quoted sometimes.
And just to add one.
Abstinence-only studies, that's done by people with the intent to show that it does work.
I mean, the data on this are very clear.
And just to add one, other spin on that, I think initially when PEPFAR, the President's Emergency Response to AIDS, that was initiated by President Bush to deal with AIDS around the world, and particularly sub-Saharan Africa, devoted a huge amount of funding to abstinence only and mandated it, and clinics could only sign up for the program if they were willing to sign on to that type of education. And the same thing, studies found absolutely was not. But Judy may have more to say about this.
Well, no, I'm glad you brought that up. But the good news was there was a huge amount of pushback, and eventually the program became more balanced. It was totally political, and in fact, many of us in this room know personally people at WACh who desperately wanted it to be. WACh is the Office of the Global AIDS Coordinator, which runs PEPFAR. And these are people who are evidence-based and certainly wanted the balance to be more evidence, in favor of evidence-based approaches. So over time, it moved. But it was horrible at the beginning. It was awful.
The question is, can anyone address what's going on locally in middle schools and high schools around reproductive health and possible distribution of contraceptives?
As was mentioned earlier, it's variable. Now, if you're in the Seattle public school districts, there are a number of middle schools, and all of the high schools have full-service clinics where you can go without, consent or awareness of your parents and get contraceptives and get, STD testing and your whole range of health benefits. They were started because they wanted to make sure that people had access to reproductive health, but they're much more comprehensive than that, which is, it's hard to get that message sometimes because people think, oh, I'm not going, it's a birth control clinic, but they need to go if they, it's a great way for kids to have access to health care. But I think it's variable in terms of the education. Even in Seattle proper, there are schools that don't teach sex ed, or whatever they teach is really inadequate. There's the FLASH program, which has been endorsed. That's a sex ed teach education program here that's actually very nice. But it's not taught with the integrity of the curriculum in every school with every module, and not all schools use it because, again, you don't have to teach sex education. But if you do, you're supposed to use a good model, but you don't have to. So even in, within 5 miles, there's differences here.
Specifically with the private school system in Seattle, and I think in a lot of other places, it's treading in really murky water because they're privately affiliated, they have the option to do whatever they want. And then if you put religious influence in the picture, it just gets real tricky. In my school, it took about 2 years before we were able to get the Teen Council program to come in, and that was only last year. And before that, they were doing their own program. They had their own resources. It was very, very private. Students didn't really know much about it or where they were getting the information from before Planned Parenthood went in. And actually, the Teen Council program from Bellevue went into my school last year about 2 or 3 times, and only to the freshman class. So it was very limited in which classes they went into.
On the infection side, and that is that, we now have the HPV vaccine. Target population is teenage girls. That's the highest priority population, especially 9 to 12-year-olds, although it can, the focus is prior to initiation of sex. People should have this. We know very clearly that the most effective national strategy would be to deliver this through schools. The United States is doing particularly badly compared to other countries in terms of getting our girls immunized. This is one of the safest, most effective vaccines that's ever been developed, and it's a vaccine that prevents cervical cancer. I mean, it's a wonderful agent, and because of the issues we're talking about, most schools are not willing to have HPV vaccine provided through the schools. So, the education issues are important, the contraceptive services access issues are important, but we should also be thinking about it in terms of eliminating cervical cancer.
Just to add to that, in Seattle proper, where we have the school-based health clinics, the rate of kids who get all 3 vaccines is actually higher than the national average, but the national average of girls, women, who get that HPV vaccine and get the 3rd dose is less than 30%, right around 30%. So, it's very, there's some studies that maybe, you could do well with just having 2, but only 70% or so of people across the country may get their first shot, and it just drops down from there. So we haven't done a good job of, in this country, as many other countries have done.
Well, I think that we've hit past 7, so we probably better wrap up. This has been a fascinating discussion, and a huge thank you to our panel. And and next week we have, it's a little bit of a different subject matter. It's going to be how technologies are being employed to tackle under-resourced, underfunded, neglected diseases in the developing world. So we'll have folks from the UW, of course, and then an attorney who works with PATH as well as teaches here, and somebody from the Gates Foundation. So we hope you all can join us for our last session, and good night.